Hello. If any of you feel like moving up a little bit closer, for us as the panel, what we see is a bank of lights and then a whole lot of chairs. If you move a little more close, it'll feel a little bit more intimate from this end. The panel have promised me that they would like to answer any questions that you throw at them, and they want to see how provocative you can be. This session, Priya tells me from the NCD Alliance, who are running this session with HelpAge, that they would like you to go away understanding some of the barriers and the context around that, but also understanding that there are solutions, there's places to go, there's ways to address the sorts of issues that we face as we go through the life course, as we go through our journey of humanity and the health that we need to take us through that all the way through and for those that we care about. To give you a little bit of context for the session, I'll just give a little bit of an overview and I'm going to then introduce my panelists here. Each of them will give a bit of a 2 or 3 minute introduction to themselves and their expertise areas and what they would like to let you know. Then we're going to give it a go for the questions right at the beginning. So start thinking in your mind, see what's challenged, see what you'd like to get out of this, and we'll go from there. So the quality of care a person receives throughout their life, from infancy and childhood through to adolescence, has a significant impact on health and their well-being. That's no surprise. And the global epidemic of NCDs, including cancer, cardiovascular disease, chronic and respiratory disease, diabetes, mental health, neurological conditions, these can exact a heavy toll and a disproportionate toll, depending on who you are, where you're born, and your access to care and services. These present not just health barriers or challenges inside families and communities, but they're barriers to economic opportunities as well. They're exacerbated by poverty, by vulnerable situations. There's a particular impact on women, children, and older persons who are disproportionately affected. So what we like to think about in the health world is ways to achieve quality of care which is safe, which is effective, which is timely, efficient, and which is equitable, and which is people-centered. So when we think about this, we have a number of different levers that we can use, including the Universal Declaration on Human Rights. We can think about the rights for people with disabilities. And what's enshrined in there is an ambition for enjoyment of the highest attainable standard of physical and mental health. And that has 4 components: availability, accessibility, acceptability, and quality. But in order to achieve those rights, we must overcome a number of barriers and challenges, and this is where our panel of experts come in. And they would tell you, and I would tell you, that we need to have meaningful involvement with people in the planning as well as the service delivery, in the development as well as in the metrics, with follow-up and with quality care. So this session focuses on something called the life course approach. And the life course approach aims at increasing the effectiveness of interventions throughout a person's life, from a healthy start at life, and it targets needs of people at critical periods and vulnerable periods throughout their life. It promotes timely investments, a high rate of return for public health, and its comparative benefits on the economy, and it looks at the causes, not just the consequences of ill health. So the adoption of a life course approach aims to improve health and well-being overall of the person, of the family, of the community, and it talks to development and inclusive growth. So our experts here represent, and I've clumsily tried to order them on the journey of a person's life. We'll see how it works. It may not. But first off, we have Dr. Faisal Elkak, who I sort of thought he's a bit of a chicken and egg guy. So he's obstetrics, and critical interventions around safe motherhood. Faisal will introduce himself in a minute. Then we'll be followed by Dr. Felix Managotti, who works in terms of rural women, also around maternal health and youth. Margaret Cabango, oh, sorry, I've gone out of order already. Helen next. Helen from AstraZeneca. And she's going to give her, well, she says she's not an expert in all areas, but she works with a lot of experts. So she's going to channel the expertise that she's exposed to through her work and focus in the adolescent area. And then we'll go to Margaret. Margaret will talk about the other end of life, which is a little bit more the quiet end. I'm hearing an awful lot about youth as I come around the centre. I've heard youth for 2 days. I haven't heard anything much about aged persons and aged women in particular, and Margaret will help us fill that gap with her experiences. And then we'll have Dr. Princess Nono from WHO, and she's going to give us the whole package. No challenge there, no. But at WHO, she has a responsibility for looking in an integrated way across programming for the life course as from her work throughout her career, but also now as a special advisor to the Director General. So let's start off with Dr. Faisal El-Kak. So please introduce yourself and tell us what we need to know and start stimulating the juices of the audience.
Thank you, Susan, very much, and thank you for being here. I'm Faisal El-Kak. I'm an obstetrician gynecologist. I'm also a professor of public health. And I'm here in my capacity as the Vice President of FIGO. And I cannot help, if you allow me, Madam Chair, to note that apparently health is becoming less appealing in women deliver. That's why I thank you again for being here. And I strongly believe, as a provider and as FIGO, that a healthy woman is an empowered woman. And I think we cannot achieve the goals of Women Deliver and the slogans of Women Deliver if the women we are trying to assist, to help, to work with, and everything is not healthy. And that's why I think in this session today, we're gonna show how important it is to keep health a priority across the lifespan of women. Thank you.
Thank you very much for this opportunity. My name is Dr. Felix Manyogote, as introduced by Susan, and I'm passionate on maternal health, and this is something I would like to share with you today. Just as an introduction, in the year 2013, I lost my aunt in Kigoma village of Western Tanzania on childbirth, and this was due to obstructed labor and excessive bleeding. Nobody were aware that this was something that could be preventable. And to be honest, my aunt's death put a face in each and every maternal mortality I could hear. So while on medical school, I decided to make a research and to identify what is the major causes or problems of maternal mortalities in Tanzania. And from my researches, I came to learn out that most of the rural women in Tanzania lack access to basic health information and services. And about 60% of rural women never see a doctor throughout their lifetime of pregnancy. And this is because of long distance of travel to access the health services. And then I decided to take action and found the Mama Afya initiative that works to provide free door-to-door antenatal health services in rural areas, which includes free health screenings of danger signs of pregnancy to pregnant women, and providing tips on healthy lifestyles for pregnant women and other women throughout their lifetime. Thank you.
Thank you. Helen?
Thank you. So it's on. My name's Helen, and as Susan introduced, I come from, I guess, the corporate side of the equation, and for the past 20 years, I've been working in the space of cross-sector partnerships, and the last 10 years specifically with AstraZeneca and partnerships focused on adolescent health and disease prevention. So when I say I'm not an expert, I mean, like, I have the great privilege of working with a lot of NGO partners who are active on the ground in the field, addressing a lot of these issues in the adolescent health space. And so the perspectives that I'll share today are really coming from my partners and from the programs that they're implementing and the philanthropic work that we're doing in this space. So it's a great privilege to be here. And what I will hopefully bring in are some of the challenges that we see on the ground in countries around the world when it comes to young girls and boys accessing healthcare and the right that they have to healthcare, but also some of the ways we're trying to address those challenges through sort of positive, creative, collaborative solutions with local governments and other NGO partners. So I'm looking forward to the questions that you'll have for us. And I know youth have been much more on the agenda lately, especially here at this event, but even in other global events, we are seeing much more about young people, but I still think we have a long way to go. So that would be my provocative question to you guys: is what can we do to increase this even more? Thank you.
Okay. Margaret?
I'm Margaret Kabango from Uganda. My theme here is to talk about the health issues of older women in Uganda. What barriers they have towards accessing health. I have worked with older women throughout my career. I'm a physiotherapist by profession, and through working with them, I interacted and learned about all the challenges they face regarding health issues. So I became an activist. I decided that something must be done in a teamwork, of course, not me alone, to see that health services for older persons and older women in particular should be improved. So I decided that that's my activism now, to insist that older women and men, of course, should be prioritized in health issues so that they can continue to live a meaningful life.
Thank you. Well, thank you very much for putting all of this together, everybody that's contributed to this session. I must say it's an honor, because for the last 30 years of working, first as an obstetrician gynecologist in my country, and now the honor of working in WHO, this is the first panel where we have had an older person. So this is a breakthrough. I've never been on any panel where we've actually had an older person speaking to the issues. A lot of us are slowly getting there, and perhaps this generation of young people that's in Women Deliver Now need to remember that it's going to come. So we need that same consistent focus on the life course. I'm here representing WHO. As Susan has said, I have been just given the opportunity to really work with everybody across the lifespan. It was extremely refreshing to arrive in WHO 2 years ago to find that there actually was a division for older people. There was a team working on this issue. Not any time in my life had I seen an institution that's doing that. I'm sure there are many such institutions in the developed countries, but not in developing countries. So it is a big step, I think, that WHO has taken. There are many member states that are now having an aging population, and I hope that there will be a lot of exchanges across the regions so that we are prepared and we support countries that are still struggling to really move forward. So this is the work that's happening, and a lot of evidence is coming out that shows that the investments across the life course make sense. So my message, which I hope people can take, is that we've got to move health outside of the health space. It must be multi-sectoral. It's got to involve all of government. Otherwise, it's totally irrelevant. So if we just focus on one sector, we're going to lose it, because you will see and hear from the needs of older people that we need a safe environment. We need a safe place, not just the facility. And I hope that this is the message that will come out of this conversation that we will have. Thank you very much.
Thank you very much. And I forgot to introduce myself. My name's Susan Brown. I'm with Gavi, the Vaccine Alliance, and we're an alliance made of WHO and UNICEF and the World Bank and the Gates Foundation, a number of countries who sit on our board, CSOs, the private sector, bilateral donors and so on. And if we do our job properly, we provide vaccines for immunisation for children. The good news is there's going to be loads more older people. So we will have to face this as a health community. So hopefully people like me will be out of work and people like you will have lots more people to deal with. So why don't we try just to see, has anyone got any questions for these amazing experts on the panel? Thinking around the life course, thinking around barriers that you might find as programmers, as policymakers, as activists, as people on the front lines and service deliverers, as measurers, or just as people interested in looking at health in the life course and thinking about health and how it interacts with the other sectors of society, the other policy areas that we work with. I do have a list of questions here that I can just go through, but this is our list of questions, not yours. Okay, so we're starting to get some, that's great. And I also want to say one more thing, which is any compliments for the makeup of the panel should go to Priya from NCD Alliance, who organised it all, so thank you very much. But over here, I think we had our first question. So if you could say who you are and where you're from, keep it to a nice crisp question and let us know who on the panel that you would like to address the question, or whether it's more than one.
Thank you very much. My name is Dr. Ann Kihara. I'm of the African Federation of Obstetrician and Gynecologists, Africa. This is my question. In the life course, we're very keen nowadays to bring on the adolescent and also women in reproductive age. My concern is with the older woman. One, in Africa, as the caregiver that is busy taking care of her family or even the extended and particularly the grandchildren, and they're presenting late in the medical system when they do develop NCDs. What's your take and how can we address this? Because I'm certain in a lot of the African countries, the policy environment and access in its comprehensive definition is a big problem.
Thank you very much. Well, Margaret, this absolutely sounds like you to start with, and then if anyone else wants to jump in.
Thank you very much. I had thought that there was no one interested in older women, as somebody said initially. I'm so happy to have that opportunity. Older women in Uganda, for example, are not prioritized in health plans, are not given priority. They are not included in all the health plans. And especially when they have reached the menopause, of course, nobody mentions anything. You said you had experience of gynecology. Nobody thinks about menopause as a key issue which can have repercussions. It has a lot. You can develop this incontinence, cancers of different types, prolapses. All those no older women has been told anything about. So when you get your menopause, you keep quiet, and it's a private matter. And especially the women in the village, in the rural areas. Some of them haven't even gone to school. They have just been mothers and grandmothers. So they wouldn't know what to do. Quiet with that, which is very dangerous for them. And we've think this is it is high time they started including them in those plans, and menopause should be in the forefront because it has a lot of repercussions. Personally, I've had an experience of a cousin who had her menopause, and long before then, after that, she started bleeding. She was too shy to tell her son or relatives around, but she has confidence in me. I happened to have visited the village. Then she told me aside and said, you know what is happening to me, ABCD. So I immediately called her son. I explained because she was too shy to talk to her son. This is a private matter. So I told her son, you must take your mother. I told him the dangers which could be there, cancer or what else, we don't know. So I said, take her to a referral hospital where the gynecologists can do something. So she was indeed taken, and they did an immediate total abdominal hysterectomy. And that lady is still living now, 84, and she contributes to the family. I think that type of thing, what we want, to be considered, to be visible, not to be left out at all. Thank you.
Okay. So that's at the individual level. Now, how do we get that in terms of the programmatic and the policy space to be a priority? Nono, do you have some thoughts on?
Yes. No, I think the work that we are doing now in WHO, and that has been done already by many others in the developed world, is going to assist countries. As you know, we've now got a guideline for integrated care for older people, which places older people at the center. So this whole discussion around UHC needs really to come into the life course so that we don't do verticalization of programs, but we try and get the continuum going in the health system from primary care through to tertiary. So those things are there now in the guidelines. The service benefit packages are being defined for UHC, but they have to be informed by the experiences that we are hearing now. So we've got a campaign that's going to be starting to combat ageism. From 2020, the UN will adopt the Decade for Healthy Aging, which will then lift the political issues around this matter. And then the standards and the guidelines are being rolled out to support countries. But it's clear the data is not there. Governments are not focusing. Beyond the age of 60, 65, the statistics don't count. And if you don't count it, it doesn't get done. Nobody knows what's happening. So there's a lot of challenges, a lot of region and national contexts that need to be dealt with. We were having a conversation in WHO around ageism, and the concepts in the North might not always fit the concepts in the South, which is why we've got to make it an organic issue from the ground. But if you're going to put the whole mandate on the health sector, we've lost it already. So my big message, multi-sectorality. So heads of state must hear that, because that investment must come from the states. Thank you.
All right, so multi-sectorality, integration, WHO are lifting it up into, I don't know whether it will become a sort of a package or a program or a campaign or something like that. But then ideally you want it to come back to the ground level. And I'm wondering, Felix and Faisal, how does this sound to you to bring something like this back to the ground level? What does it mean in the areas that you work in? Thinking about in the rural space, your aunt, how could your aunt have got the benefit of something like this? What would you need to make that work?
Yes, I think as my colleagues stated before here, it's very important to start from the ground level to the grassroots to the national level and to the multi-sectorial level. So I think the best way is to start with the policies, improving the policies to access the health care from the grassroots level up to the national level. This is the best thing to start with, and also to to make sure that the availability of healthy services, which means having enough healthy centers. Sometimes people, doesn't mean that they don't want to have access to healthy service, but the issue is on the healthy centers. There is no availability of healthy centers. So I think it's very important also for the government levels, for the national levels, to consider the availability of healthy centers to the nearby, to the villages, or to keep close the healthy centers to the villagers or to the citizen. I believe when the healthy centers are in place, it's very easy even for the women to have access to healthy service.
Okay, thank you. And Faisal, and then I'm going to come to you, Helen, to see how the private sector can help with this.
Well, I have to be provocative here. I think over the past 50 years or more, we have committed a strategic, not a mistake, but a mishap. And that's because of the overwhelming maternal child health issues on the agenda of health. And that's very genuine, and that's very important, because women delivery started yesterday, and by yesterday and today, 1,600 women would have lost their lives because of pregnancy and childbirth, and that's important. But because of this overwhelming issue of maternal health, over health agendas and funders' agendas and policy agendas over the past 40 or 50 years, the issue of menopause and aging women and older age have been marginalized. Only to come back now with the burden of NCDs and, of course, the prolongation of lifespan of women. What I'm suggesting here as FIGO, and in FIGO we have a specialized committee on menopause and older age that looks into all the guidelines, all the engagement. What I'm suggesting is to have a continuous dialogue between the community, because you have to break the naming and shaming around menopause, around the older age, and you have to tell people that they have the chance to live 30 years and 40 years after menopause, and they deserve to live a quality life and a dignified life. So this communication should be happening between the community and the grassroots, lobbying groups for older age women, and the provider, the gynecologists, the midwives, and other colleagues, to engage more women, to give them safe space in the service, that older age is being serviced and serviced well in this. And of course, for the policymaker to put more money and to put more or create better legislation to allow older age women to be part of the UHC and part of the SDG targets that we all are aiming after in 2030.
Yeah.
Thank you. And Helen, well, I mean, I'm glad to hear that we can live another 30 or 40 years beyond menopause. I'll take 30. But we want to live good, healthy years, don't we? I am going to get to questions again in a minute. I just thought we'd sort of dig down into this one a little bit, so I hope you indulge me there. Helen, how do we give us your thoughts on this matter, and how are we going to live good quality lives for those 30 to 40 years extra?
So I can answer from the perspective of the work that we're doing with young people, and I didn't want to make the assumption that everybody in the room is, we've mentioned non-communicable diseases or NCDs, and just to set the context that they are the #1 cause of death and disability worldwide, killing more than 41 million people every year. But what we're also seeing is that these conditions are showing up earlier and earlier. And it's really absurd to think that all the time that has been spent over the past 2 decades in improving maternal and child health and increasing survivor rates for children up to the age of 5, we're now losing them in their teens, or we are finding that we don't really know what the health of adolescents is, because we're not really focusing in on them. So my perspective is really at looking at how we can address the health and improve the health and well-being of young people, which means that they are living healthier lives as adults, and to mitigate the onset of non-communicable diseases like cancer, respiratory disease, diabetes, and heart disease and push these things off to later. So if we look,
No, but we don't want them later. That's
no,
the point.
well, we don't want them at all, I suppose. But I mean, disease is disease. Like as your body ages, these things happen, and I think that happens quite naturally. But if we're looking at the opportunity to shift the trajectory of this burden, I think we do have to look at young people. And the fact is that they are under-researched, under-resourced, and underserved when it comes to the global health agenda. And there are several partners in the room here. I see Michelle Farmer from NCD Child as well, who are working actively to change this. But on the fact is that 70% of premature deaths from NCDs are linked to behaviors that first appear in adolescence. And that adolescents, especially adolescent girls and young girls, do face significant barriers to accessing care for many different reasons. And so I think that we should turn our attention there and also look at the community level. I think there's great opportunity in UHC, and the key asks from UHC 2030, one of which is, looking at primary healthcare as a foundation and the potential opportunity for primary healthcare delivering prevention and kind of that taking that life course approach and not always thinking about treatment. I think that's what I would say. I don't have as many comments on the aging side. I haven't done as much work in that space.
All right. Well, okay, 1 minute, and then I'm just going to prepare you. I want to look for someone in the audience who is a health policy maker at the national or the provincial government level to say and to see if you'll give us a minute on what's your response to what you've heard in terms of making policy that supports older people, which is multi-sectoral, which does get to the people who need it, which takes from the ground level up and turns it into something where there's policy, where there's funding, where there's programming, where there are services and health centres, and what might have worked in your particular area to help address these questions. But Faisal, you wanted to jump in?
Just to add to my colleague, for the first time in several countries now, the number one cause of maternal mortality is NCDs. In the UK, in specific, I think Hani is here, 60% is indirect maternal. Indirect maternal meaning it's because of NCDs that we fail to prevent, probably during adolescence and during early adult life. So this is not only coming back to the older age and coming back to women around menopause or in the reproductive age, it's coming back to pregnancy, which is happening in general among women in their younger ages. So 60% as compared to the classical things we know like postpartum hemorrhage and the others. So NCD is even affecting now young pregnant women.
All right, so we've got a bunch of priorities coming up here, and if you're a policymaker and you've got this much of a budget and you've got a minister to please, you've got to sort of sort out your programming, loads of people are telling you my disease, my issue, my bit of the life cycle is the priority. How do you make your decisions, and what helps you make successful decisions? And has anyone here got an experience in making a decision over these sorts of things, particularly in the age bit? Let's just sort of finish that one. Anyone?
Thank you very much for this very interesting session. I am from Iraq, and I'm an obstetrician and gynecologist, and I worked many years as a clinician. Then I changed I worked as in programming at the Ministry of Health. Then now I joined UNICEF Iraq country office.
Okay.
So I will reflect on what I have seen, and also I am honored to be a member of the VIGO and the Iraqi Society of OBGYN. So I will reflect from my experience about this life course approach and how we can translate it into the professional and healthcare provider. Because we have, for example, in our country, we have the reproductive, maternal, newborn, child, and adolescent health strategies that it covers the all these perspectives from programming, from all as maternal, neonatal, child health. It includes even component for menopause at country level, at the Minister of Health and so on, and all these areas, prevention and management of cancer and so on, all these. But how to translate it into those who are working in the front line, let's say. I think one of the success that to unify our messages to the government from all who are working on the ground. Supportive UN agency, whether WHO, UNICEF, UNFPA, all those who are, according to their mandate, should unify the same messages, if we say the life course approach. And the societies, because I was talking, we attended yesterday the MDSR session, which was very interesting session, and I said that one of the main success made in countries in the maternal death surveillance and response system in establishing that, because it is supported and promoted by the national society through the VIGOs, in addition to the support that given by the international agencies in the country to the government. So all these gathered effort, it will bring up the professionals or the frontline workers about the importance of these issues. So we have to tackle this issue from different perspectives, different points of view, so that all those who are working in the country talking the same language. And this is some reflection from my experience.
Thank you. So unified messages, and get the support, get the echo happening from the international organizations, the UN organizations, from civil society, from others. Is there anyone else at the policy level who's having to make these sorts of decisions, and what helps you make the decisions to set the priorities around these kind of life course areas? There's not enough policymakers in the world, is there? What about one more? Let's try for a civil society activist who is actually at the not so much working at the ground level, but pushing at the government in terms of the priority setting, the national programming.
Hi, thanks so much. My name is Eppu Mikkonen and I work for the government of Finland as gender advisor. And this is more of a kind of reflection really, but when you're talking about how do you take forward the message of life course in terms of development, I think that one of the biggest, or kind of where the biggest power comes really is kind of changing the narrative in terms of development, because we've so long had this story of vulnerable groups. And I remember when we were all sitting around the table before the SDGs, and there were 20 plus groups represented, older persons, disabled, women, and the point was to prove that the group that you were represented was the poorest and most vulnerable, which is utter nonsense. So I think what happens with life course is that you start to understand the whole context and the structure differently. So instead of kind of setting one part of your life against another, you start to think in terms of the transitions and the risks that are coming through the transitions in the context that you're in. So I think it's a mindset that shifts, and that is really important. And then through that, when you start to think about policies and strategies, you think completely differently, because you don't go in a siloed, vulnerable group. No one is vulnerable inherently. It is the environment that makes us vulnerable.
I'm seeing a lot of nodding there. All right, we had loads of hands for questions. This lady just here.
My name is Kausar Afsan. I'm from Bangladesh. So in Bangladesh, actually in the government document, I would like to say, there is also, the elderly care is already included. So when I first saw that, I was quite surprised that, it's like a whole continuum of care. But in terms of actions, I think that integration is not very structured. But I can give you an example of an NGO. Although my NGO is black, but I would like to talk about another NGO who, as you mentioned about the frontline workers, so I would like to touch on that community-based program. and this is Gano Shasto Kendra, and that is also based in Bangladesh. They have a program, and that started from birth to elderly care. And I saw the program, that how they have been trained, the frontline workers in the community, to serve the elderly populations. So that's not only that the disease prevention, diseases, it's also the preventions. You know, for the elderly, you need many types of support, like health prevention care, and some of the care actually we don't think about. And I was very surprised when I saw their program, the community health workers actually cutting the nails and brushing hair, that kind of support. So I was quite, I mean, that intrigued my mind. So how can you, that we talk about integration, but we sometimes forget that how that integration could be happen, because from our perspective, because we work in the health system, we always think that one should be very much trained as a professional to provide a disease, a treatment of diseases or prevention of diseases. But we don't think about the other kind of support that one should be integrated within the system. So I would like to bring that example, because that could support the health policy makers and practitioners, that how could be taken into actions in the community.
Thank you. Yeah.
Can I comment on that? Just as I think from the private sector, I completely agree, and the programs that we have been investing in and supporting are holistic. You know, they look at a range of risk factors, but also layering on the things around sexual and reproductive health, looking at it from a gender equality perspective, looking at the communities from an environmental perspective. And I often get pushback on that, because, you know, funders or they want to work with you in one disease area or on one risk factor. And even within my own company, I get, you know, some countries, well, the issue in our area is really respiratory disease, so we really just want to look at tobacco use and air pollution. And so this idea of keeping things siloed, or keeping things within a clinic, or keeping things within a health system, it's not really helpful, yet this is how so much of the world is structured, and I think we just have to fight against that a lot of the time. And I spend a lot of my time pushing back and saying, you know, well, with my lens of young people, we have to consider a young person as a whole person, and all of the many different things that impact that person's life. I think, as the woman from Finland mentioned, you know, we are not vulnerable. We are vulnerable because of sort of other issues and situations that are around us. And so it's impossible not to think about that broader environment and community, I think.
So and so that's a lot of us are more and more trained in the micro speciality, but the message that I'm hearing here is that when you're trying to set the programming, you need to lift yourself up to the generalist level, think about the whole person, think about the whole life, and think about integration in the other policy areas, and not necessarily compete for who's the most vulnerable, who's the most deserving. Although, I mean, there's a political reality that we all operate in, isn't there, in terms of getting the decision makers to focus to achieve ambition in our area, because as people who are activists, and I would hope many of the people at Women Deliver are activists, we want change, we want betterment, so we need to get the decision makers to start focusing in our area so we can bring those resources down. Now, I've got Faisal here, but then also, Nono, just to prepare you, I wanted to come to you because WHO is moving in that direction now and thinking about things from a holistic perspective, thinking about a healthy life rather than just a disease-specific approach. So I'll give you your public service announcement time to let the audience know, but Faisal first.
Just to add to Helen's point, see, when you bring all these programs, and you would love them to be like integrated and look at the woman as a whole and everything, but you're asking people who have been trained for 20 years on dysfunction all the time. Doctors, they are in dysfunction, they are subspecialized, respiratory, gastroenterology, this and that, and then you tell them, listen, You have to listen to the woman, you have to talk about gender-based violence, you have to talk about integrated care, you have to talk about preventive measures, health maintenance, and so on and so forth. Unless you create a new curricular changes that will look at the woman as a whole, or men as a whole, and this will align with all these upcoming policies and the program. Otherwise, you will be doing a policy and a program for providers or implementers who are not able to see the whole picture.
All right, and then maybe we'll hear from Felix and Margaret on the way to Nono. And Nono, you can kind of wrap this bit of the segment up around the holistic approach. So Felix, do you have any?
Actually, I still insist on the policies and programs from the grassroots level to the national level, as my colleague has spoke. Yeah.
All right, and Margaret, any?
The holistic approach would be an excellent idea, but it should be stressed that all ages should be considered important, because with our countries where the budget is about 8% of the national budget instead of 15, which the Abuja Declaration, recommended, you will find that there will be a stage when they will say, we cannot afford this, you see? So there must be a mechanism, maybe through guidelines from the World Health Organization, to insist that this holistic approach must include all ages. Then some of us who have been left out will not be left out. That's very key, because we are also important.
All right, now Nono, you have access to more health ministers probably than all of the rest of us. How do you get this message? You've got these ideas, and you know, let us know how WHO is thinking in terms of the holistic and life cycle approach. But how do you get health ministers to take that up, to go back to the national level and start implementing, start actually taking these ideas up and progressing them at national level?
I just want to affirm the point that the delegate from Finland made. I think we should not be talking to ministers of health. Okay. That must be the big change. Heads
They're
of
the
states,
ones that come to you. The finance ministers don't come to you.
That's the point. That is the problem, Susan. And that is what needs to change, the mindset. Honestly, the mindset. Because if we see the holistic picture, the environment, everything, it's got to be a whole of government. So I think what we should be trying to get is a health assembly, not just of ministers of health. Something needs to shift. That whole narrative must change. And it means we must be prepared to give up our spaces, because we all come here with a little space. That's the elephant in the room. We've got to be prepared to get out of the logomania, you know? All the logos up there, people are not single issue logo people. This is evident. So if we, the activist community, don't change the narrative, then we're missing the point. We really are missing the point. So the changes in WHO now are big, massive. You are never going to see in the transformation the little disease that you want to fund as a donor. That's a massive shift. And I think we've got to acknowledge the DG for this. It's a bold move. Member states are pushing back, because where's my little disease that I can fund, that I can count how many people? Gavi, you talk about the people you vaccinated, and I challenge you that baby comes with mother into the clinic. If you count those vaccinations, why are we not asking the mom, how are you? In that interaction. So you go back. I mean, the inequities are incredible. Faisal, we are talking about what's happening in the UK. In the African region, women enter pregnancy already on the negative. Anemic, malnourished, it's a tragedy. On the other side, we're not talking to the private sector. That's the big elephant in the room. The constant messaging to young people, alcohol, tobacco, food. I've never seen a society where we're promoting fish and chips for breakfast. It's, you know, really, that's the work we need to do. So the bigger structural changes are important, but we must refuse to be pulled into this verticalization of women and young women's bodies. We must refuse. And that means giving up my little space as WHO, your little space as Gavi, your little space as UNICEF, your little space as... It's a big mind shift. And I really think my take home is what you've just said. That shift must happen. And if we are doing it through the transformation, I hope the UN reform does the same, and then maybe we stand a chance with heads of government to see that this is what we need. I really hope that this is what we fight for as the activists, 8,000 strong here.
So who's convinced by this? Who is going to walk away from this session thinking, how do I make a more integrative narrative? Okay, and is that a change for you? Were you already doing it, or is this helping kind of feed the thinking here? All right, and I've got a 5-minute wrap up. So I think the sorts of things that I'm hearing here are around health plans, definitely around the grassroots piece, the stories at the grassroots level that actually represent the sort of issues that we need to deal with. The integrated piece, the thinking about the person, the holistic person all the way through from birth or before conception, right through to age, that extra 40 years that we all want. From the frontline workers right through to the policy makers, thinking about the joined up narrative, thinking about celebrating the micro-speciality and the knowledge you have, but knowing that as an activist, you've got to put it all together and lift up to the general level, the all boats should rise type approach, and changing the narrative and emphasis on the way through, and a continuous dialogue from the programmatic level to the policy level. I'm going to turn it to the panelists for 30 seconds each. It's not enough time for this session, but it is all that we have. So I think we'll start. Faisal, would you like to start? Just sort of 1 minute each. What would you like the audience here to walk away with? What would you like them to do? What would you like to think that you have stimulated in terms of this conversation? What do they need to do in all of the areas that they can approach as they walk out the door?
I just thought of one statement.
Okay.
That the most famous one is no one is left behind. I would love to say no age is left behind.
All right. It gives an extra 30 seconds to Felix too.
Okay, thank you. For me, I would like to let everyone here know that maternal health is not just a woman issue, it is a society issue. So let's all of us get responsible to hold the government from the grassroots levels up to the national levels. Thank you.
Thank you. Helen?
I don't know how to sum up. I did hear a lot of questions from you, Susan, around policy, and I don't think that there was as much discussion along these lines, but I think that if we can build better evidence to support a good policy, that will help create the change to have some of these things that are being discussed by other people. I think that maybe investing in that evidence to make that the case to policymakers would be something we should do more of. And we didn't get as much discussion about that in here today, so that would be my contribution. Yeah.
All right, we need another session like this, but more on the policy end. I'll go for that one. Margaret?
I would like to say exactly what Dr. Faisal said. No age should be left out. We are all important and we matter, equal opportunities, and we should all shine and be visible.
Thank you. I think for me, the only point that I would like to make is that there are systems in the community. Let's empower them. You know, there's this preoccupation with primary health care. Not everything needs to be neat in a box, you know, in a guideline, to me, you know, not to you, Susan, but there are systems in the community, you know, and they are not too costly. Exactly. We need to invest in those. Really, people can make and develop solutions for themselves. No system is left behind. Exactly, exactly. And we've got the ground information. We've got a system in place. There is something happening at the community level. There are community workers going into in and out of households. If we can teach them that if you are in that house to look after the pregnant woman, do the whole thing. It's not very complicated. We'd really take to make it complicated because, you know, it's our nature to do things. So I'd love to see us moving from primary into the community and really get people to make healthy choices. So the message to government is make healthy choices easy for people. Don't ask them.
Make healthy choices easy for people. Yeah. So with that, I'd like to thank the panelists. I would also like to thank NCD Alliance, HelpAge International and FIGO, who were the organisers of this session. And to thank you all for coming, for your questions. I'm sorry we didn't get to as many of you as put your hands up, but change the narrative as you walk out of here. Don't leave the systems behind, and don't leave any ages behind. Thank you.
Thanks, Sue. Thank you.